Thank you so much. Thanks, Amy, and thank you all. It's been such a great day. Secretary Azar, welcome. Thank you so much for joining us. So we've had a full day of discussion today, and we've talked about a lot of themes around what actually can create a person-first health system. It's been super collaborative and solution-focused, so it's been really exciting. And I want to start off just by saying, so just a couple panels ago, we had a session called sort of Providers Are People Too. It was really focused on the healthcare workforce, so I'm going to call this panel, sometimes we get a little disconnected from our policymakers, and so I'm going to call this panel Policymakers Are People Too. And I want to start with a person-first perspective with you, and that would be really to just ask you what connects you personally, if anything, to this idea of a person-first health system, and do you have your own best and worst that sort of illuminate the idea of person-first in your mind?
I'm a consumer of healthcare. My family is a consumer of healthcare in the American system. I've gotten to see it, good, bad, ugly, warts and all. And I've tried to use those incidents not to drive policy, but to cause inquiry to see if they're systemic or if they're just anecdotal to me. And what I found is my bad experiences tend to be evidence of a systemic issue. So I talk a lot about an issue I had on surprise medical bills and lack of transparency that drove a lot of my passion in this space. I was a patient back in Indiana, and long before I was secretary, it was when I was at Eli Lilly. And my doctor wanted me to go off a certain medicine that I was on, and my cardiologist said, well, let's do an echocardio stress test. Just want to make sure everything's good before we take you off of this, because otherwise everything looks good. And do you have time to do that? Oh, sure. Got time. Brought my shorts and my sneakers. We can do it. And I figured, well, we're going to walk next door to a little room, and I'll hop on the treadmill and get plugged in and do that. But instead, a nurse is walking me to the elevator. We get on the elevator. We go down into the tubes like a subway tunnel, those ugly yellowish tiles and everything. And we emerge in another building, and I come up, and I'm seated in front of a woman who's at a computer. Name, social security number, date of birth, insurance card, ID. And all of a sudden, a plastic wristband comes out and gets slapped on me. I'm like, whoa, wait a second here. I think I've just gotten admitted. And then I get marched to the cardiac lab. This is the place where people are coming in off of ambulances with heart attacks and where people are getting quadruple bypasses. And I'm here for an echocardio stress test. So I'm thinking I've got a high deductible plan at that point. And I'm thinking to myself, oy vey, I'm in a hospital. And so I go up to the desk and I say, hey, I've got a high deductible plan. I'm paying for this myself. What's this echocardio stress test going to cost? We can't tell you. I said, well, why don't you get me a manager? So after enough kicking and screaming, a manager comes out. I said, what's this going to cost me? Can't tell you. I said, no, here's the thing, I'm the president of Eli Lilly, and I'm the former Deputy Secretary of Health of the United States. So if you don't tell me there's going to be an op-ed in the Wall Street Journal tomorrow talking about all of this, okay, I'll tell you. So let's just say if you pay cash, that it's $5,500. And I said, okay, $5,500. All right, well, I've got insurance, so even though they're not paying, what's the negotiated rate? I can't tell you. I said, okay, let's do this again. Blah, 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 op-ed in the Wall Street Journal. And he said, well, I can't tell you the negotiated rate, but let's just wink, wink, nod, nod, say it would be $3,300 if you pay cash. I said, okay. So I went on Harvard Pilgrim at the time, had a great app where you could look up different procedures and get a sense of what they should cost. I don't know if they still do. But I sort of knew what it should be, and I confirmed, yep, it should be about $500 if you had an echocardio stress in your cardiologist's office. And instead, I'm getting the discount of $3,300 for this. So I ripped off the plastic wristband and left the hospital and didn't get this done because, in my math, I could have flown back to D.C., had my old cardiologist here on K Street at GW, who was President Bush's cardiologist in the White House. I could have flown back with my wife, first class, stayed at a suite in the Four Seasons in Georgetown, had him do the echocardio stress in his office, spend the whole weekend here, fly back to Indianapolis, have him ship the results back to my cardiologist there, and I still would have been ahead financially. And I'm like, that's just crazy stuff. So, we all have these experiences. I mean, I had that. I can go, all these stories, they're stories, but they're things that every other person in the American healthcare system has to deal with. But because of my privileged position at the top of it, I see it and can have an impact on it. And I can see if it's emblematic of a systemic issue, and by God it is. Surprise medical bills. I mean, I had that. I had plastic surgery when my kid had to get stitches at a surprise medical bill. I mean, I've dealt with the lack of interoperability of EMRs as secretary. I was the Secretary of Health, and I was it's in the papers. I was admitted for diverticulitis, and I go to my primary care doctor that's owned by the same entity that owns the tertiary hospital where I was an inpatient. And what medicines are you on? Like, do you not literally have the discharge notes and discharge information from the hospital? Well, no, they're on a different system. They're Epic and we're Athena. It doesn't talk. Okay. So then I had to go and get a CAT scan. Well, so they send me to a CAT scan that's owned by the same facility. I go there, same drill. What medicines are you on? What are you here for? Blah, blah, blah. Do you not talk? Nope, different system. So some of that helps drive that. And then, just issues of patient-centric care and patient at the center and the lack of economics in running our healthcare system. I'm in my motorcade, and we're on the way from my primary over to the CAT scan, and my insurer, Anthem, calls and says, well, we see that you have an appointment. You're going to the St. Vincent's CAT scan. If you went to this other one, it would save $2,000. And I said, will it save me $2,000? No, it'll save us $2,000. I said, I don't really care. I have an appointment.
I don't know if you've been listening in to this like all day with, I know you're a very busy man, you've been running around. Like the very first session we had was on patient journey mapping, and you have just outlined several patient journey maps, and I don't know, but I'm sort of sensing a line from those to like your work as secretary on transparency and interoperability.
Transparency, interoperability. And then my father went through the entire patient journey in kidney care, and as a result, I got to see all the problems with center-based dialysis, crashing into dialysis, transplantation system, all of that. So I reformed the entire system, moved to a value-based preventative system for CKD progression, changed the entire transplantation system, changed all the financial incentives towards basically keeping people off of dialysis, having it be home-based if they have to be on dialysis, incentivizing pre-dialysis transplantation if possible. So all this, but you get informed by experience because you have to be out there engaging, but these weren't sort of personal issues to me, but rather I'm able to see this stuff needs fixed.
Yeah. It's fascinating. And we talked earlier about how policymakers, like at the federal level, at the HHS level, when you're creating these new models, like how do you actually get input from real people, right? Like you're drawing on your own experience, obviously. I think there's a lot of those kinds of stories of, the people in power who, like their wife had a problem at the getting a contact lens filled or whatever, and so they have the power to do something. Now there are so many more engagement mechanisms to kind of get a sense of like what is going on with people in communities. I'm curious,
Not good.
How that's going.
I mean, honestly, the mechanisms for getting that input are not as well developed as you would think or hope. Like if I could sort of do it over again, and God no, but if I could do it over again, I do. You just don't have the time or the vehicles to really get that type of input from patients or input from stakeholders as much as I think in retrospect, like, oh, I wish I had known that, or I wish I had been able to connect with all these groups before making that decision, or bring them along, all the things. You're just moving with your hair on fire.
Yeah.
It's so fast. And everything's such a crisis. You don't tag all the bases, but we don't. Those especially at the highest level, those mechanisms for that kind of patient journey marketing, the kind of marketing input that at Lilly we would have like lived on. You just don't have the vehicles for that.
Yeah. Well, we have some ideas from today, so maybe those are things that can get advanced down the road. So speaking of, being at the highest levels of government, from that personal to professional, obviously you've been at Lilly, you were deputy secretary, obviously you were secretary. What was your proudest accomplishment?
For me, it has to be Operation Warp Speed. That was my baby. created that. I think I was uniquely in the role as secretary at that time because I was able to bring the experience running a large part of a drug company, knowing how R&D works, knowing the incentive structures within a pharma company, and also understanding the mechanisms of power and money in the government and how that works. Because we don't talk about this a lot, but under President Bush, working with Mike Levitt, I helped architect the first ever pandemic plans, and something you don't hear a lot about was an industrial planning program for flu vaccine. I mean, most of you in this room are too young to remember in 2004 when Chiron's Liverpool manufacturing failed in the middle of an election. We had no flu vaccine in America and had to ration it. And there were and it was sort of my first big exposure in government of how can you use the power of government to fix a market failure? And what are those tools? How can you create markets, build markets, solve incentive structures when the private sector isn't delivering what you need it to deliver? And for Warp Speed, that's what I did, merged those concepts, and that's how I created the vehicles of basically de-risking every aspect of development and manufacturing and commercial enterprise, pre-funding all of that, taking money completely off the table, and placing a pharma company portfolio-style approach of multiple mechanisms of action, multiple molecules within each, redundant manufacturing, pre-making commercial-scale manufacturing at risk. People don't know this. We were making over 100 million doses of vaccine in July of 2020 when we were still in phase 1 and phase 2 of clinical trials. We were already producing. That's how we had close to 100 million doses of vaccine by the end of the year. Oh, that was of the approved ones.
Yeah.
Let alone the ones that didn't eventually make it, that we had the product for.
You had that, yeah. And we were talking earlier about harnessing the power of the private sector and markets, and how do you do that, and how do you harness the best of the public and private sectors and create better partnerships? And Operation Warp Speed is such a great example of that. And I'm curious, like, what would you say to future innovators who are looking to maybe learn from that example? And then how do you tie that back to this idea of, person first, person centered? Curious. That's sort of two very big questions, but.
So Operation Warp Speed, it gets bandied about a lot by people because it, thank God, ended up being miraculously this success. And it gets thrown around, well, we need an Operation Warp Speed for Alzheimer's or for cancer, for this, that, and the other. And it, frankly, comes a lot from people who don't understand the mechanisms of why did Operation Warp Speed work. And it say cancer, for Operation Warp Speed for cancer. That's sort of a meaningless question, frankly, because of course there are thousands of different cancers. And Warp Speed wasn't about discovery. It wasn't, oh my goodness, we don't know what the molecule is, we don't know what the genetic sequence is, we don't have targets, we don't have even vaccine candidates. We had 140 vaccine candidates. We knew we had a vaccinable virus. Why? I mean, we knew that this was a vaccinable virus. I mean, compare it to HIV/AIDS. How's it different? Other than one documented case, nobody has ever cured themselves of HIV/AIDS. The body can't cure itself. The body can, for most of us, cure itself of COVID. The body can react, it can produce antibodies. So my job is, can I trick your body into thinking you had COVID and get you to produce the antibodies? That's literally the task, and the body can do it, I just have to trick it. And that's what the vaccines are. So it's about execution. It becomes about how do you use the brute force and power of the government, working with, not against, the private sector, to solve their incentive structures, all the things that make them go slow, all of the risk mitigation steps they take because they have shareholders that we can take away and remove execution risk and remove financial risk from that table. So if you have a validated target, say on a cancer molecule, and it's just about powering through it, yeah, that could be it. But Alzheimer's, take Alzheimer's. I mean, we still don't for sure know that we're dealing, on the beta amyloid hypothesis, or on tau tangles, or we've got some therapies getting approved, but we still don't really fully know Alzheimer's. So that's not one you just power through it. Would be the thing. So I think it gets thrown about a lot by people who don't understand the microeconomics of it, which is unfortunate. Patient-centric, I'm not sure there's a tie-in necessarily, except of course try to save lives. But
that's a good start.
I mean,
That's a good start.
That'd be probably the biggest patient-centric aspect. Save several million lives if you can.
Yeah, there you go. That's great. Well, it's funny because earlier we were talking about kind of understanding markets and understanding, frankly, the business of healthcare. And it's been sort of woven through sort of the day, right? Like this idea of, I mean, I think everyone in this room wants like person-centered. Everyone sort of from across the sector wants these aspects of person-centered, but the profit incentives are sort of challenging. The business incentives are challenging. And you were talking earlier about a class that you teach on that and that it's getting kind of increasingly harder to do health policy without understanding that. I'm just curious, like, if you think that has changed or if you think it's even more important nowadays, or like, what do you wish policy knew about business and vice versa?
I mean, I wish everybody involved in health policy would take at least 1 or 2 microeconomics classes and at least spend some time in the healthcare industry where they've got to think about a P&L and how that functions. The challenge is, for me, I step back and I say, why does healthcare not function like every other part of the economy? Every other part of our economy, quality goes up, price goes down, the patient, the consumer's at the center, it's built around them as a decider. Why is healthcare not that way? Why are we having meetings where we have to convene to talk about how do we make healthcare patient-centric? We have trillions and trillions. We have 1/7 of the American economy in this space, and we can't figure out like how the patients that should be at the center of that, like televisions or cell phones or anything else. Well, there's a reason. I mean, I had a professor. I'm a recovering lawyer. I'm not a health policy person. And for reasons I can't explain, other than he was a great professor, I took zoning, land use controls when I was at Yale. And Bob Ellickson, my professor, used to say, when you're taking Metro North into the city and you see burnt out buildings like townhouses and buildings and the land not being at least plowed over to be a parking lot in Manhattan, like land not being put to its highest and best use, ask yourself a question. How's the government involved here? Like somehow, if markets aren't functioning, there's at least a good hypothesis the government has screwed this up. Some regulatory aspect, some government control is keeping efficient markets from clearing. So ask yourself, where is that? Healthcare, we are littered with that. I mean, it goes back to the 1930s when we created health insurance as prepaid health care tied to employers, tax subsidized, and separated the financing from the purchasing decision. And once you've done that, you've completely divorced the price and quality mechanism from acting, and you have, at that very moment, you've disempowered the patient as a consumer, and you've made the system from that moment in the 1930s non-patient-centric. So the question becomes, well, we're not going to, I think even the wildest of us and most revolutionary are not going to try to blow up the employer-sponsored system or the notion of insurance and prepaid health care. I mean, that's just not going to happen. So then, well, there might be someone who would want to, but I'm not quite willing to take that on yet.
There's a few of them out there.
But for me, it's how can you create proxies? How within the framework of that type of a system can you make it function more like the patient at the center, more like the patient as consumer, more create the incentives for the players to compete for that patient, to delight that patient, to deliver quality and reduce price. You're not going to get perfect as long as you have a prepaid healthcare with financing divorced from purchasing. But you can make steps that get you closer.
Take steps to get, and from a messaging perspective, how do you talk about that without scaring people that like who are already concerned about their finances or don't have $400 in the bank? Like, how would you have changed it instead of your insurance company calling you in your motorcade and saying, hey, you could save money if you just like scoot over here instead?
I'd have it so I actually could save money. Give me money. Make it relevant to me.
Yeah.
I mean, if there were $1,000 at play for me on that choice, you betcha I would have said, we're going there.
Yeah.
But it wasn't. I didn't have any skin in that game. So give me skin in the game. That's why differential cost sharing. The whole notion of patient-centric care, or what's the term? The patient-first health system. I used patient-centric. Mike Levitt before was more called value-based. Was the initial framing of this. The whole notion is, okay, how do you put the patient at the center, have the system built around them? So you need transparency, because you can't have a price system without price information. So price and quality information. You need, for competitive markets, you need pricing information. You need portability of patients. The patient has to be able to move where they want to go. That means that you need to have non-captive markets. You need to have EMR systems that are portable and owned by the patient, so the patient's data doesn't have them captive somewhere. You need to have payment systems that align a provider with a patient. Why is that? People often criticize the notion of patient-centric and the patient at the center, as if we're trying to create this shopper, the ultimate healthcare shopper, who's going to be having a heart attack in the ambulance and deciding which hospital to go to as they search on Google for the best quality, lowest price per hospital to go to for their heart attack. That's not what we're talking about. First off, that's not actually how efficient markets work. Markets clear with limited information with a small number of super consumers. A very small number of coupon clippers drive economic behaviors, whether it's at Walmart or Target or could be in healthcare. You don't need super consumers to drive this. But secondly, for the patient, I've never had the vision of the patient as an atomized individual adrift on Google doing searching. But rather it's how do you get the patient paired with a learned intermediary, whether it's primary care or otherwise, where you have aligned incentives. So that somebody is actually caring for that person, but with the right incentives, not the incentive to churn and burn on procedures and diagnostics, but rather the financial incentives to deliver better outcomes, the kind of outcomes the patient wants, staying out of the hospital, longer term better health outcomes, et cetera, lower cost. And that's where that's why changing the payment systems becomes very, very important. And for me, the best thing I could think of was capitating payment at the provider level around total cost of care to create that aligned interest with the patient. But
So a lot to talk about there. I mean, you know, we hear these terms batted about a lot, right? Like Washington loves to come up with buzzwords, and you know, sometimes then you run the risk of you're saying everything and saying nothing. So that's why we've worked so hard to kind of try to create some very specific hallmarks of what is a person-first system. And we hear, you know, kind of aspects of this, at least I do, from kind of both sides of the aisle, like person-first, patient-first. There's even some new polling out, some new messaging research that says, you know, people don't really like the term value-based care. That's kind of a wonky word. They think that means they're going to get less quality care, but you know, they like the term patient first. They like the term, you know, they like the idea of quality. So like, is there a way, do you think, that sort of framing things as person first, patient first can have traction on both sides of the aisle across sectors? And then like, is there an aspect of a shared vision that you think can be moved forward?
So on the last question, shared vision, absolutely yes. It's actually probably one of the more optimistic. I don't tend to be terribly optimistic, but I tend to be very optimistic about the fact that really starting with Mike Levitt on a frankly unbroken string through to me, and I'm sure into Secretary Becerra, there's been a deep commitment towards moving to whether you call it value-based care or patient-centric care, outcomes-based payment systems. That's been a remarkably nonpartisan view. I think because we don't see none of us see any great alternative. And so it's sort of this way or nothing has been the approach. In terms of the marketing vision around patient-centric or value-based or whatever else, I can only tell you what my vision is, which is my vision of healthcare is that everybody in America would feel cared for in the system and feel that they have concierge care. That they have, and it doesn't have to necessarily be a primary care doctor, but it could be. It could be virtual, it could be AI-based, it could be more intensive for certain people than other people. But nobody should have to feel alone and adrift in the system because I'm the health secretary. I can't navigate the system by myself, okay? We all need help in a complex system. And so getting players that can have aligned incentives who take care of you so that you feel cared for and feel shepherded in the system, not paternalistically shepherded, but aligned shepherded in the system. I mean, that for me is the vision.
Yeah, it's fascinating. You know, it's remarkable how much similarity there is with, you know, one of the hallmarks we talked about was this idea of my care team is here for me. I have an integrated supportive care team. We talked earlier, many people brought up, we talked about the healthcare workforce, like, can you have a healthcare quarterback? Can community health workers be part of the answer, right?
I get jealous sometimes when, like, I would go up and visit up in Anchorage and see some of the Alaska Native Medical Center facilities there. There's I don't know if Demetrius, if you remember the name of it, but it was part of the ANMC, I believe, that a primary care clinic center, where it was this complete hub system. Like, every patient, you had nurses, behavioral health, physicians, everybody in this whole like care team built around you. And a lot of our federally qualified community health centers have that. One of the companies that I'm on the board of, Absolute Care, we do that for managed Medicaid patients. And, I mean, in a way, you're like, wow, that's a great way to deliver care, because I'm sure very few of us in the room actually have that type of experience of sort of a feeling you have a team. You probably end up, like me, being the aggregator of a team. Yep. And if you drop a ball, it's going to drop because it's all hanging on you to figure out your health care at the center of that.
Yep. Absolutely, absolutely, and it's falling on caregivers and unpaid family caregivers, and
absolutely.
A lot of we're talking about women, especially, not to be biased or it falls on the individual. So I want to ask you one question, and then we will have time to take, I think, like maybe 2 audience questions. But so we had talked about the vision, and change is hard, and the status quo is it's just pretty hard to change. And, people, someone earlier talked about being a radical incrementalist. I think there's some new research out too. Like, people don't like big change, or they see,
not in healthcare.
Or there's change, and someone in the audience was asking me earlier, but like, so maybe there's all this change in Washington, but like, when do I see the effect of the change, right? So like, how do you move as a leader? How do you think about moving from vision to reality to results?
Yep.
And how do you what tools or tactics have you employed or found useful along your journey?
So whether in the public or private sector, the most important thing is know where you're going. So having a very clear definition. You're not going to start in Maryland and end up in California if you don't start and set the vision you're going to California at the start. Why you want to go, I don't know, but assume you do. You need to know that, or you're just going to accidentally end up in Montana or wherever else, a great state. But that's going to happen. So setting the vision as a team, deciding where you're going, what is the end state you're aiming towards, and then creating what are the building blocks, the X to Y by when strategic imperatives you have to achieve to get you to there. And then what is the execution framework to make a large bureaucratic organization actually do what it doesn't want to do, which is change and do something different, just fighting the middle management inertia that every organization faces. I mean, I helped collaborate on a book called The 4 Disciplines of Execution that Franklin Covey put out, that is an execution tool that talks about how do you do these things, but it really uses JFK and LBJ on going to the moon. Okay, you set a vision. The initial vision, actually, that JFK articulated was to send a man to Mars and return him safely to Earth. And NASA pushed back and said, no, that's not going to happen. And said, how about the moon? Oh, okay, moon. So moon. So the team, sort of like a conveyor belt, did a negotiation, came up with goal. Send a man to the moon safely and return him to Earth, alive. Okay? What do you have to do to get that done? Well, you have to solve propulsion, you have to solve navigation, and you have to solve reentry. Okay, so there were 3 key, I think those were 3 key problems that had to be solved or you weren't going to get there. So you then solve them by 1969. And you have then a cadence of accountability of how do you actually get that done. So for me, that whether government or private sector, it's about that. But the other key thing that I've learned over decades now doing massive, massive transformation in the private sector and the public sector is it is very hard to get organizations or individuals to change when they view it as a zero-sum game. When by changing, I lose and someone else benefits. It is a lot easier to make change happen when you add money into the system, when you add benefit into the system. Listen, there's a reason the system is the way it is right now. People are making money off of it, okay? The entrenched players, it's working for them. It is not in their interest to change that system, either to go lower or to run the risk of going lower if they don't successfully execute the change. So for me, I've always been of the view that it's worth investing more money into this system, as expensive as it already is, to build the new patterns of behavior and muscle memory of delivering, whether we call it value-based care, patient-centric care, patient-first care, whatever you want to call it, so that you're not, by that change, defining winners and losers, but rather getting the new systems and muscle memory functioning. And if your bet is right, if we are correct that this is the way to move away from fee-for-service and actually reduce costs and improve outcome in the long run, you will in fact reduce costs and improve outcomes in the long run, and the money you spent will be a small investment in comparison for a very large decrease in price and cost over the long run. But you have to be willing to eat a bit of cost up front as an investment. I found this at Lilly. I would have loved to do this at government if it weren't for OMB and budget neutrality on CMI models, because I do believe this. I think it's just basic organizational and human behavior.
Yeah, it's fascinating. So, I mean, is there any path forward? Like, is there a change you would make to sort of help foster more of that longer term thinking then? If you could wave a magic wand and make something different happen?
Yeah, I'd waive budget neutrality in the CMMI framework with OMB. Because, I mean, even like kidney care models, you have like after 1 year, someone said, we haven't seen savings on kidney care. 1 year into 1 year into converting to trying to prevent the progression of CKD, and you think you're going to see cost results in one. I mean, at that point, you're still aligning patients and getting them into a medical home and trying to get them on the therapies to deal with some of the things like diabetes, hypertension, et cetera, that are going to like slow that progression. It's just some of the way people who don't deal with organizations and haven't run them and haven't been in them, they don't get the issues that have to come along. That actuaries or others, they don't get that.
Yeah.
And it's a very short-term kind of just like, it's all about the pennies. That's just like how we end up on social determinants of health. We end up penny wise, pound foolish, because you play to the scorecard you have, and our scorecard is expenditures, is short-term immediate expenditures. And so we don't end up, doing some of the things like put a ramp at someone's house that will keep them out of a nursing home.
Yeah.
Put an air conditioner in their house that'll keep them out of the hospital. Things like that. We don't think that way, again, because our payment systems aren't aligned. But if you actually empower the providers to own total cost of care with upside and downside, then they can place bets on social determinants of health that will in fact save money for them and for the system and for the patient. And you can drive forward, where with the models we have now, the people up on Security Boulevard sit there worrying about churn and burn. Oh, well, then we'll get a ramp industry. Then we'll get an air conditioner industry, and everyone will just more, because there's no accountability for delivering results. They're not placing bets that have to deliver. If you change the systems to capitation with total cost of care, you actually are but then you have to get the heck out of the way. Let them place the bets. Get out of the way. Stop thinking a procedure-based way. I mean, I almost pulled my hair out recently when the whole debate was about nursing home staffing levels. I'm like, I've never understood the notion that CMS regulates how many people are on a floor, and it's like, really? This is how, we talk about bureaucratic. I mean, we're not paying for whether a patient gets out and is walking when they leave a nursing home, that'd be the standard, not how many nurses do you have at what hours on a floor? Pay for the safety, pay for the outcome, but they always want to, in business we say, they say, tell me the what, not the how.
Yeah.
The government wants to tell you not just the what, sort of, but really wants to tell you the how.
Yeah, and earlier some of our panelists were talking about how do you even take it even further step back, and is walking what the person wanted, or is it to see their daughter get married, or to visit their, and how do you account for that? So, I mean, in reflecting on what you're, we don't have a good way to
even measuring the desire. We faced this a lot when Lily, when you dealt with mental illness. For a patient, we can sit back and decide that it's losing symptoms in the latest DSM, but to the person who's suffering atypical psychosis, they might say, it's having a girlfriend, it's having an apartment, it's having a job, it's being able to go on a date. That's their definition of health and success, and that may not be in the DSM. But again, they're not always good vehicles for listening to the patient.
Right.
And finding out what do they define as the right outcome. And that is a risk for us as we think about value-based or outcome-based care, is that the outcome becomes what we say the outcome is, not what a patient would want as an outcome. So that is a good caution on everything else I've said.
Yeah, that's super helpful. Well, I promised a couple of audience questions, so we really do have time for two questions. Keep your questions brief and focused on the topic at hand. And I saw your hand and your hand, so you get first dibs. All right, go ahead.
I was just reflecting on what you were saying on supply and demand, and wanted to get your thoughts on how to address when markets don't necessarily serve people who need care because it's just not profitable. Mm-hmm. So, for example, maternity care deserts, mm-hmm. where there are large sections of the country without obstetric services. Okay. So again, just wanted to get your thoughts on how we may address that.
So I'd look at that, and I have looked at that, as an economic issue. Why is that not happening? Why are there deserts? Okay, so one, let's think about supply. Are we requiring that it be OBGYNs? Are we preventing doulas and others, other caregivers, to be able to provide? I mean, I had one governor who used to complain to me, all my rural hospitals are closing. My rural hospitals are closing. I don't have enough doctors out in the rural part of my state. I said, well, do you allow NPs and PAs and doulas and midwives to practice to the top of their license? No, the doctors would kill me. I'm like, well, then I'm not talking to you till you do. So first, solve the artificial constraints on competition and trade that would allow highly trained people to be able to deliver in those areas and do things in those areas. The other is, are you putting enough money into it? Okay, so that is an incentive issue, that the payers, the system is not necessarily paying enough to pull in the resources. So that is something that's an incentive structure that just the market's just telling you you're underpaying. Your price mechanism isn't working, so you would have to pay. You have to care. I mean, that's probably the core of your question is, do you care to fix it? Mm-hmm. But if you care to fix it, then yes, you would want to increase rates to draw people in. You need to have the right aligned incentive structures. So on maternal mortality issues, are we actually incentivizing the payments around proper prenatal, proper delivery, and proper postnatal care for the baby and for the mother? Are we doing that? And are you paying? Because you get what you pay for. So that's one. And then just good systems of accountability. So do we treat a maternal mortality event as a never event in this country? Mm-hmm. That every single maternal mortality is one that requires an investigation, just like leaving a scalpel inside of a patient. Why did it happen? What's the root cause? How does it not happen again? And the states that have had significant progress on maternal mortality are states that have commissions that actually do that type of work.
Thank you.
Hi, thanks Secretary Azar for your comments, and as an infectious diseases physician at Kaiser Permanente, I thank you for Operation Warp Speed. I had a question about how to best align patient and insurer incentives. So you had mentioned the example of the possibility of being diverted to another facility and how there was no direct incentive to the member or to the person to go there. But if we think about how that incentive could be applied to lower premiums across an entire population, for example, in infectious diseases, we'll have high-cost drugs that come out. There's no efficacy advantage, but there's direct-to-consumer marketing. It looks flashy, it's exciting, and it's new. And we sometimes have to have conversations around, this isn't going to help you, and it's not going to cost you more, but it's going to cost the system more, and therefore it's going to cost everybody more, you included. But that's hard to sell, and that's a hard conversation to have. So do you have concepts on how to better align that, or how to better explain that on a population level?
So this will be me from a more ideological perspective. I don't believe you can convert people into altruists. And so I don't think you can take someone and get them to respond to societal or population level benefits that are not there. Now, actually, where you work, Kaiser has been a unique contra-example of that. The Kaiser population, the patient base of Kaiser ever since the beginning, but certainly lately, is a population base where those more communitarian messages historically have worked, where it works to say you're not going to get this more expensive therapy because that's too expensive for the system and for other patients and for access for others. And that message actually works. But this is also one reason why, I don't know if you've been around Kaiser for a long time, Kaiser tried to move into North Carolina at one point, and it did not work. It works in Northern California, it works in the DC government employee area, completely failed in North Carolina, where that kind of message just would, that system of sort of sacrifice for community benefit wasn't going to resonate. And so you're in a unique pocket where there are people that sort of self-select into Kaiser, knowing that is the ethos. But not to get old F.A. von Hayek on people, but I think the fatal conceit of socialism was that you can remake men and women's incentive structures. And you can't, I don't think you can. I think they are what they are, and you sort of deal with them. So.
It's really interesting. Well, thank you. That's fascinating questions. Okay, so I said I was going to have one last question after they announced, but I actually have two last questions. My first question is, can I take your class at University of Miami?
Sure.
Okay, because I think with you and Secretary Shalala, that sounded like a really fun class, so I'm going to sign up. And then, it's so great to have you here, Secretary Azar, and of course, want to give you the opportunity in our last few minutes to say anything else that you sort of didn't get to say, but I'm going to ask you to sort of say it too. If you got to shake hands with the brand newest employee at HHS who is like just stepping into their career, what would you tell them? What advice would you give them?
Well, I'd say you're embarking on a career what people find fulfilling and engaging in a career is having an important role on something that's important. And I mean, the data shows over and over again that it's about having an important role on something that's important. And I would say to them, you're coming to a place where your work could not be more important. And if you have an important role, whether you have an important role or not is up to you. You have the option here because even with 85,000 employees, it's still a department where people run around with their hair on fire. With 330 programs and a $1.4 trillion budget, it is actually not heavily staffed for the nature of the mission and the size of programs. And so as a very young person, I certainly benefited from this throughout my career, you can have absurd levels of responsibility, accountability, and impact if you take advantage of that. If you put yourself out there, if you do it, you work hard, you take on the work, you can have an incredibly fulfilling, important role on things that are the most important things on earth. That would be the message to anybody starting at HHS.
I love that. We're going to capture that. And Demetrius, would you agree? He was your boss too, so there you go. That's fantastic. Well, thank you. Let me ask if there's anything else you want to share, or are we?
No, we originally had conceived of this. We were hoping to be able to get one of my Democratic colleagues, because I do a lot of events with my colleagues.
Yeah.
And I think it's important for the country to know that, in spite of all the really horrible things that go on in the broader political world, that in this world of health, whether Democrat or Republican, I'd say probably 85% of the things we generally actually agree on the direction of what we need to do. We might talk in different language about it, but we're sort of aiming in the same direction. I might talk microeconomics, and Secretary Becerra might talk equity, but we're probably ending up in the same place on a lot of things. And frankly, on the other 15%, we don't beat our heads against each other, because we're not going to convince each other on those core belief structure questions. And that's how Donna Shalala and I get along so well. We literally share an office. We have 2 desks in a little office there at Miami. And we're great friends. And we agree on so much because most of us who are deep in health policy recognize the direction things need to go, as we've talked about. And we need to be together, and I think it'd be reassuring for the American public to know more just how much we do work together and think together and get along in that space.
That's fantastic. Well, thank you so much, Secretary Azar, and on behalf of our entire board and our team and all of us here today and those who will be watching the recording, thank you so much for joining us and really offering us those words of inspiration and hope for forward progress on building a more person-first health system. So let me hear a round of applause for the Secretary. Thank you.
Thank you.
Thank you.